Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot. And today, I'm delighted to be welcoming Maggie Ehrenfried. She is the Managing Director of Development at LifeNet. Maggie, thanks for joining me today.
Well, thank you, Nick. I appreciate it. It's a pleasure to be here.
So for those listening, it would be helpful if you could just share a brief background of what LifeNet is and what they do.
Absolutely, I'd be happy to. So at LifeNet International, we believe that every individual should have the opportunity to live a healthy and whole life. And we're committed to making sure that's a reality for the poor and the vulnerable. We're actually motivated by our faith, and we act out of compassion with our medical and business acumen. You may not know this, but there are thousands of faith-based health facilities throughout sub-Saharan Africa, and they were all started with a mission to heal the sick and care for their communities. Unfortunately, there's a lack of resources and knowledge that often prevents the fulfillment of this mission. And that's really why we were founded. Our founder is a businessman from the US that saw that simple solutions implemented at these health facilities could really radically improve the care that they provide. And also on the management side of the facilities, these simple solutions could ensure the sustainability of the health facility so that they could actually care well for their communities for the long term. So that's really why and how we were founded. And our goal is to transform these faith-based facilities to provide high-quality healthcare in financially sustainable ways that will allow them to care well for their communities for the long term.
So one of the things about faith-based care is that that's a pretty substantial contribution to what's going on in these areas. What's going on there? Why is that the case?
It's a massive market in sub-Saharan Africa. The WHO actually estimates that somewhere between 40 and 70% of all healthcare services in sub-Saharan Africa are provided by faith-based facilities. That obviously varies by specific location, but that's still a massive market, even if you're looking at the minimum, the 40%. And what's more is that these facilities, they're often serving the most underserved or hard to reach populations. That's sort of built into their ethos and their mission. So if you really want to impact the hardest to reach or provide care for the quote unquote last mile, as many say, then working with faith-based healthcare systems is truly a must.
But in fact, in Africa, it's not really the last mile, is it? It's like, it's a lot further than that in many instances.
That's right. That's right. So many of these patients, the only access that they have to care is these faith-based facilities, again, in a hard to reach place, but they're walking 1 to 2 days to access these facilities. And it's truly their only point of care. It would be impossible to make it to a large city or even to another health facility that is, say, 3 or 4 days away.
That's exactly right. I think it's really important for people to understand that, and I just want to re-emphasize it. But I'm familiar with that. Going for care, a visit to the GP, we complain about the 20-minute drive. These people are going days in some cases because they're so remote, and that ability not only to provide that care to those distributed communities, but I think also in many instances there's a projection. So I've certainly come across some of these healthcare support services that project out into the communities so that they have visiting clinics and in the case of maternity, doulas and midwife type roles that actually project out. Is that part of the work that you do as well?
So we don't specifically work with those individuals. They're often called community health workers, and they go from either the health facility or the community itself into homes and far-reaching areas of the communities. And they're really providing sort of that first point of care and saying, hey, you need to head on into the facility. You do have a problem and you need to go be seen. So there's a lot of organizations, NGOs, local organizations, even local governments that are working with community health workers. And we are really improving the care at the facility. So when a patient is referred to a health facility, if the care there is not good, then the system really breaks down. And what LifeNet does is make sure that the care at the facility is high quality. So if a doula or a community health worker, whoever that might be, refers to the facility, they then can get the care that they need.
Excellent. So, completely different environment to the one that many are familiar with. And one of the things that you really focus on when you think about small improvements is trying to be an additive, or I would say an amplification of the existing services. Is that true?
Yeah, that's right. We are really focused on sort of this idea of asset-based development. We believe that these communities have incredible resources and skills and knowledge, and that those things should be capitalized on. We really want to mobilize the community around the resources that they have already to solve their own problems. And so that's what LifeNet does. We use each community's own assets to improve healthcare. So we are essentially equipping and empowering health workers to better use the resources that they already have to ensure that their communities can receive good care. So we're just capitalizing.
Yeah, so can you give us an example of how that works? I mean, give us a specific instance where LifeNet has gone in, existing service. How do you amplify? What's involved in that?
Sure, absolutely. Well, I'll give you one example here is just simple hand washing. The WHO estimates that if we hand wash consistently, and this is true for the entire world.
Yes, it is. Pay attention, folks. Not to diminish it, but we actually have seen surveys here where even in our own hospitals we have a problem. So yeah, pay attention.
We absolutely do. So hand washing, if it's implemented, it can reduce infections by 70% at health facilities, which is a massive number, especially when you think about the number of deaths that are caused by infection. So in each of the countries that we operate, actually infections are one of the top killers. It's a preventable killer, obviously, if you just wash your hands. And so what we are doing is basically teaching the health workers to implement hand washing. And if there are no resources like running water and soap, then what are the things that we can use and do that you do have access to make sure that your hands are clean, so that in between patients you're not sharing germs, you're not creating those infections, and you're not raising the death rate essentially just by not washing hands. So small tweaks.
Right. So small incremental changes, and the one I want to focus on, it's kind of interesting because we don't think about it because we've got for the most part regular running water, it's clean and so forth. What do you do in circumstances? How do you support a situation where there is no running water? What's involved there?
Yeah, well, there are commodities. Just as we have Purell hand sanitizer here, there are commodities that are alcohol-based that are sanitizers that can be used. And some of these facilities don't have the setup to have access to those supply chains, and that's a big part of what LifeNet does as well. So we not only provide training for health workers and managers at facilities, but we also really ensure that the facilities have access to the supply chains that they need, whether that's for commodities, pharmaceuticals, or equipment, so that they can do things like clean their hands in between patients.
So it feels a little bit like the sort of incremental approach that LifeNet takes to this is that you're essentially going for a root cause analysis of, what are the problems that are inhibiting this? In this case, the example that you've cited is hand washing, huge impact downstream, but, the problems are different because of the circumstances, but they're not insolvable. And there's methodologies to allow you to both find that and then actually address the missing resources and find solutions.
Absolutely. That's exactly what LifeNet does.
So as you think about that and the resources that go into doing that, what's involved? What's LifeNet's sort of business model? How do you go about that, and how do you do that cost effectively?
Yeah, great question. Well, this has been a long time in the making. When we were first founded, it was simply an idea to make these small tweaks within the health facilities for a large impact. And we did 3 years of researching and prototyping and iterating. So it was really a lot of work to understand the comprehensive nature of the problems, to really ensure that we had local input, that we weren't coming in as Westerners and deciding what the problem was and creating our own solution, but instead listening to a local voice and creating solutions for the problems that were brought forth. We have medical experts and also business experts that were helping to develop our curriculum during that time, and really making sure that what we were doing was in line with international standards, with Ministry of Health standards in each country, and with the specific needs of each health facility. So it's a continuous process. With every health facility, we do a full analysis of the facility to truly understand the unique problems, and we adapt ourselves and our curriculum to each of those problems. And same with the countries we work in. If there's a higher HIV rate in one country versus another, if that's more of a priority for the local government, then we are tweaking our focus and our curriculum to make sure that those things are being highlighted as well.
So as you think about the sort of major elements, and just to be clear, I think, LifeNet's a case study in incrementalism, which of course resonates a lot with me, the incrementalist, I just got to say. What's involved? I mean, so you've gone through that analysis, and are you delivering in services? So, to your point of the hand washing before, you're not solving the Purell supply problem, but you're enabling that. How do you go about this?
That's correct. We are essentially empowering and equipping, or as you're saying, enabling. We are looking at the landscape with the health facility, the managers, the health workers, and saying, where are the problems and where can we find the solution? So we may not know every issue within the supply chain for that health facility, but they certainly do. So together we can come up with solutions.
Thinking about that, from a financial standpoint, what are the costs involved? How do you do this?
We are unbelievably efficient. So the costs are actually
I'm sorry, those are words I never hear on this radio show.
The costs are fairly minimal, and that's because we are so focused on this idea of asset-based development, of using what is already available. So basically what LifeNet does is overlay its operations on top of existing operations. So we're not having to build a building. We're not sending people to medical school. We don't have massive capital costs. We are essentially, again, overlaying our operations on top of existing operations. So we're getting great leverage. So our small financial input, which is donor driven, creates a large output because we also are using the local resources. Our model basically prevents waste for both LifeNet and for our partner health facilities. And as you said, efficiency is an interesting topic on the show, but it costs us about $1.20 US in order to, per patient visit in order to implement these operations.
Wow, that's really low. I mean, I think in the context of the overall cost, do you have any sense of what that is relative to the costs in country, so the existing expenditure? I mean, you think about that, but I also, contextually know some of the numbers for what individuals earn or, have the capacity to live off in those countries. How does that relate to the in-country expenses?
Yeah, so patients are usually paying a fee for service. Mm-hmm. So they'll pay to see a provider. They'll pay if they need pharmaceuticals. They'll pay if they need lab work done. So the cost for a patient varies. It could be 50 cents US. It could be $3 US. So we're still talking LifeNet being in that range or less. Right. But what I think is really interesting about our efficiency is that there are other peer organizations in sub-Saharan Africa that are working within the healthcare system, whether that's community health workers, these primary care health facilities like us, and we've done our cost comparison, and we're a great option. The closest peer that we have right now, I won't name names, but they essentially are working for $2 per person per year, so we're under that. And another one that is quite famous, quite popular, that is a peer organization. Again, I won't name names, but they look at about $6 to $13 per capita. So regardless of what you're looking at, LifeNet is still a great option in terms of efficiency.
And when you say that, I mean, you're talking about the contribution or the cost involved. So if the population is 100 people, the cost is essentially based on the estimates. It's in your case $1.20 times 100 for the year. Is that? Am I understanding that correctly?
You've got that perfectly, yes. Yeah.
Okay. So significantly less, and obviously from a standpoint of value, that's a key contribution to this area, which of course is lacking all of the resources. So for those of you just joining, I'm talking to Maggie Ehrenfried. She is the Managing Director of Development at LifeNet. We were just talking about the positive contribution and an organization that is incredibly, quote, efficient, words that I don't often hear on this radio show. So opportunities for learning to understand how you do that. And I certainly want to dig in that in a second. But before I do, I want to talk a little bit more about that sort of improvement in quality that you've sort of seen for this, relatively low cost. Tell us a little bit about that and what's going on.
I'd love to. So we are really focused on improving the quality of care at these health facilities. They're already up and running. They're already providing care, but we want to make sure that care is good care. And there was actually an article that was recently published in the Lancet back in November that basically described that across low and middle income countries, poor quality of care is contributing to more deaths than non-utilization of care. So that's huge. Poor quality care is actually killing more people, than a lack of use or access to care. And that kind of goes back to what we were discussing earlier. People can access these health facilities, but what are they accessing? If they're referred there by a community health worker or a doula, what will they actually receive while they're there? Will it be good care, or could they unfortunately die of a preventable disease? And what LifeNet is looking at is making sure that no one dies of these preventable diseases, and that people do not live with long-term disease and disability that could be prevented. So that's our big push, is improving the quality of care to make sure that people are living and living well.
So it's kind of interesting that you bring that up. I mean, when you think about the lack of access, I mean, I think that's the first thing that most people would jump to as a major cause of death within, these underserved communities. But what you're saying is that the delivery of the care has quality problems that are essentially causing more deaths than that lack of access. And that's true, right? I'm getting that correct.
In low and middle income countries, it's true. Yep. In this day and age of the big push for universal health coverage, what we need to really remember is that universal health coverage is not enough. It has to be good coverage. It has to be quality care.
I have to say, it reminds me a lot of the challenge of medicine. I think Sir Cyril Chandler said something along the lines of medicine used to be very low cost, highly ineffective, and now it's very expensive and awfully dangerous, because we have a tendency not to deliver the best possible care, not through any intentional. I mean, I don't think any of this is an intentional thing. It's, a number of things in this country contribute: lack of sort of distribution of knowledge to the point of care. I'm curious to know what's contributing to that very low quality in these countries. What are the things that make that number so high?
Well, similar to what you just mentioned, even in this country, is a lack of knowledge. If the international standards and the best practices and these great protocols don't make it into the hands of health workers, they can't use them to save lives. And so LifeNet is essentially a bridge between these international standards and protocols and ways to save and improve lives, and the health workers who need them in these hard to reach places. And another situation for these health facilities in the regions that we work is a lack of access to resources. So they are hard to reach facilities, and supply chain to these areas is not easy. So it's really a lack of knowledge and resources that we're seeing.
So it's interesting. It's actually even an extension of a problem that exists here. So, good example. We know in hypertension that let's pick cardiac disease. So if somebody has a myocardial infarction, we know based on the science that they should receive an aspirin and they should receive a beta blocker, even if it's an unconfirmed myocardial infarction. So in the case of chest pain, encouraging that. Now we've gotten better, but that actual knowledge took 20 years in this country to actually reach greater than a 50% implementation in patients. And here we are, across international borders in remote areas where it can take days to come into facilities. And you're saying same problem, but, I guess amplified.
Exact same problem. They just look a little different because we're perhaps talking about different diseases.
Right. So it's essentially the same sort of distribution of knowledge. So once again, education and knowledge becomes the great liberator in this. And I imagine that those are two sort of key assets that LifeNet focuses on.
Absolutely. And I love the word liberation that you just used, because we're truly empowering health workers. They are called to this mission to care for the sick, and they so badly want to do so well. And with just a few tweaks, a few incremental changes, they're able to do that. And it's a very empowering thing for health workers and managers alike.
Yeah, so the prevailing point I have in this, I'm for the most part, I'm think like a proton, I'm always positive, and that applies to people in general. I think there's a very, very small subset that have other intentions, but the vast majority of people don't get up in the morning going, how can I damage somebody's health, life, whatever. They get up with good intentions, and we have to enable that through the distribution and the support. And as one of my previous guests puts it, make the easy choice the right choice. And in the case of hand washing, I can't think of a specific instance in your particular context, but making the hand washing the easy choice versus making it difficult so that it becomes something that people don't do. So fascinating to me as we sort of explore this, and some of the things that you've done. We've got a couple of minutes left. I just if you could, I'd like to understand, what is it that LifeNet has done that has enabled you to deliver this improvement in quality, highly cost effective, highly efficient? What's going on in your organization that we could learn from?
Well, the reason we are so focused on impact and efficiency is because we were really built as a business-minded organization. We have been measuring our results from day one, using our data to adapt our programs, making sure we're as cost-effective as possible. Our founder is a businessman, and we have had that focus from day one. So that has been a huge part of what has shaped LifeNet into the organization it is. But again, I think it's really that asset-based development focus, that we are focused on local people with local solutions for their local communities. We want to capitalize on the resources that are already available, and doing so not only provides efficiency and impact, but it really also provides for long-term behavior change.
Yeah, so it's, and my sense of that is, data. Again, I'm replete with these quotations from old people, but Lord Kelvin, I believe, is attributed to the, without data, you cannot improve. And I think you've sort of built that in as part of your incremental sort of approach to this, to say, let's understand it and apply. And I specifically heard you right at the early part of this. You talked about the 3 years to sort of get this up and configured, and that was a constant process of defining what you were going to do, how you were going to do it, and I assume testing in the market. Is that true?
That's right, absolutely. We iterated with different health facilities, and we took the feedback and the data that we got from those situations and really developed who and what we are, and we're constantly doing that. We really see ourselves as innovators, and you can't innovate unless you are measuring and responding to what you're doing.
Perfect examples of incrementalism. It sounds like LifeNet is a case study in developing an incremental solution, in this case, delivery of healthcare in my birth countries, or birth continent at least, and somewhere that I'm very passionate about. So, Maggie, thank you very much for joining me. Unfortunately, as usual, we've run out of time. Just remains to say appreciate you coming on the show.
Well, thank you, Nick. It's been a pleasure.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at HealthcareNOWradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.